People that are caring. So I'm one of the anesthesiologists. Dr. Browerly is going to be the one that you'll wake up with, but I'm the one that you'll probably go to sleep with.
Okay, my biggest concern is
Is this
That's how we update the family.
is to record it?
Uh-huh.
just me.
Just him
Just me.
and the conversation.
I have COPD,
Yep.
and you're going to collapse one of my lungs.
Yep.
That is my biggest concern, is the collapsing of the lungs, and then I flatline.
Collapsing a lung won't flatline a patient.
Okay.
That's not what does that. Usually, I mean, in very rare circumstances, can there be some other clinical factors that predispose people to that, but usually not.
Okay.
That's
my fear.
That act in and of itself.
Yeah, that's my fear.
Is
when you flatline, when you make the lung deflate.
We don't. So the flat line is a term used with cardiac heartbeat and electrical impulses. It doesn't. That's not a term that you associate
I know.
with lungs.
I'm a goofy guy. I'm a truck driver. I don't know any better. I'm sorry.
No.
But that's my concern, is that I die from the collapsed lung.
Unlikely. The biggest complication usually with collapsed lungs, first and foremost, is atelectasis, which is a collapsing of the individual air sacs that make up the lung.
Okay.
And then the other part is pneumonia postoperatively, because you're not adequately re-expanding your lung. You may have a chest tube after the case, and that will help. But if you're not up breathing and taking normal lung volume breaths, so as much as you normally would breathe in,
Right.
either with a regular breath or a sigh or a cough, sometimes that fluid or air exchange doesn't happen and it predisposes you to pneumonia.
That's why he's giving me an epidural from like here down to help with pain management, so I can do the coughing and the breathing.
To help with it, not
Right.
completely control.
Right, right.
So I don't ever promise complete control with the epidural. We hope for that, right? We
Yes,
hope
ma'am.
that it does it and it gets to the point where you can do it. I usually say tolerable. Now what's tolerable? It's different for you as it is for me, as it is for her. And so something there. What we need you to do is eat, drink when it's appropriate, right? And then coughing, walking, standing, sitting, all those different position changes from laying down to upright walking, right? So there's several different variations throughout there. That's what we need you to be able to do. Now, is it a pain-free experience? Usually not. And so that epidural will help with that. My goal, I hope and wish that it takes care of everything and you can zoom around the floor and the physical therapist is like, hold on, you're running too fast. That would be amazing.
That ain't gonna happen.
Because that didn't happen before.
Right.
No, that wasn't happening with the COPD at all.
There you go. So there's
I get up
that.
out of the chair and I'm like, give me a second.
Yeah, and so, I just encourage that whenever people have surgery, when they're working on moving and mobilization, they stop and take a breath with each position change. So when you go from laying to sitting, you haven't even moved out of the bed. You give your body time to reacclimate with gravity and your fluid status and all that sort of stuff. And so that's sort of what I indicate there. And then when you go from sitting to standing, you don't move for a good 2-3 minutes before you
Right.
take that first step.
Yep.
So that's the smart way to do things.
Yes.
Because that allows your body time to make those vascular changes that it needs to accommodate for gravity.
Absolutely.
Yeah, and so that's there. So the lung thing, while I understand that that's your biggest concern, my bigger concern is with the expansion and moving.
Is afterwards. Okay.
Is afterwards.
Right. Yes,
Do
ma'am.
weird things happen sometimes when people have severe COPD and they've lost that lung elasticity and structure? Yes. Sometimes there's holes that can form on the blebs or the COPD
Don't need to hear
outside
that.
those areas.
I know
So
you
you
have
do.
to.
There are those things, so just full disclosure on that. But
Right.
if that's the case, then we consult other teams. We have a chest tube. We talk to the lung doctors and the lung surgeons, and we evaluate if we need to, when we need to.
Right. Okay.
Our breathing tube that now in your notes you mentioned and talked about some throat pain and swallowing difficulty.
Because of the cancer.
Okay, all right. So, but mechanically swallowing, you're
Yeah.
okay,
Yeah.
fine.
Mhm.
So where is the throat pain?
Now I don't have any.
Okay.
Maybe a little bit. Like right here-ish. It's just, I mean, it's so slight, it's not even funny.
Okay. Okay.
And I think that's more from drainage.
Okay.
You know, like post-nasal
Yeah,
drip
yeah,
kind of thing.
fair
So.
enough. Okay.
But like and it's dry, I'm dry.
Yep. And the hospital's not going to help with that because
Right.
it's dry here all the
Yeah,
time.
so I mean, I think that's most of it.
The tube we use to collapse your lung is large. You're going to feel like there with something in your throat, a sore throat is sort of a sure thing.
Okay.
So it's a big tube about that big around that goes down into your mouth, vocal cords, and your lungs, because that allows us to isolate lungs
Yep.
and different immune systems. And so that'll be placed after
I'll be
your
asleep.
sleep. And it comes out before you wake up, as long as you're doing well enough for it to come out. In the event that you're not doing well enough for it to come out, you need to transition to a ventilator in the ICU for some reason. We'll swap it out for a different breathing tube, but it still may have something there. Not super likely, it's not something that's very high risk, but with these surgeries, I always say it's possible.
Yes, ma'am.
Okay, so risks to that too, hoarse voice, sore throat, soft tissue, dental damage, it might be that we need to go.
Will I be able to play the piano?
Sure.
Oh, I've never played it before.
Yeah, so there's that, right. Yeah, so people,
Ridiculous.
Sorry, it's how I deal with my stress.
that's
my
okay, I
anxiety.
get it, but people in the ICU sometimes sit up and they have a breathing tube and they write and they talk to you. And I've seen people walk around with a ventilator. All sorts of stuff happens in the hospital, right? So that's, again, not our goal, but that does happen. Any history of anesthesia problems for you?
Seizures? No.
Anesthesia problems?
Anesthesia problems.
Anesthesia problems? Not that I'm aware of, no, ma'am.
Okay, any history of people that are blood relatives to you that have difficulty with anesthesia?
Not that I'm aware of, no.
Have you ever had chest pain or a heart attack?
I've had chest pain because of the COPD, but no.
Okay. Any high blood pressure?
No, I have perfect 120/80 blood pressure.
Any heart rate problems?
Not that I'm aware of, no, ma'am.
Blood clots?
No.
Pacemaker, stents, or defibrillator placed anywhere?
No, ma'am.
Okay, any history of seizure or stroke?
No, ma'am.
Numbness, tingling anywhere that's permanent?
No.
Diabetes?
No.
Thyroid issues?
No.
Asthma?
No.
Okay, and then did you take your inhalers today?
Yes, I did.
Okay,
Trilogy.
perfect, oh, lovely. Any nebulizers involved with that, or just the?
Just the trilogy.
Okay, then any sleep apnea for you?
No, ma'am.
Heartburn?
Yeah, a little bit.
Just with food, or even when you don't eat?
Just, well, it's pretty much
All the time?
because of this. I got the G tube.
Okay.
You know, it's like, ugh.
Okay, fair enough. Any liver or kidney issues that you're aware of?
No.
Teeth that are loose, chipped, or broken?
I got horrible teeth.
Yeah, are any of them loose?
This one's broken.
That one's broken there, okay. Is that back piece loose, that little fragment there? Okay, and then how about the rest of everything?
They're all kind of, because of the chemo and stuff, they've all kind of gotten,
But they're not loose.
they're not loose like ready to,
Okay.
like, you know, tie a string around a doorknob and yank them out.
But they are loose, or have they just become less secured in the gums?
Less secured in the gums, I think, would be a better way of saying it.
Would you eat an apple?
Oh, God, no.
Okay, would you eat an apple anyways?
Well, if I can slice it, I'll eat it and chew it up. But yeah, I won't like bite into
You
an
won't
apple.
bite into an apple?
No.
Okay,
No.
alright. Any issues, and then anything removable in the mouth, partial plates, dentures,
No, ma'am.
removable things?
No.
Okay, so the first thing we'll do is we'll have you sit up, clean your back. We're gonna put the epidural in here before we head back, okay?
Does it hurt?
Well, the numbing medicine in the skin is the worst part. That's what stings, burns, and hurts, but it lasts about 3 to 5 seconds.
Okay.
Okay, so you're gonna sit up on the bed and you're gonna assume horrible positions like this. You're slumped over, shoulders are slumped, chin is down to the chest, and you're pushing that lower back out towards you.
Okay.
Doing this does not help. This helps because we need your spaces in your spine to open up, not close up, okay?
Okay.
So you'll sit on the edge of the bed. My nurse will be here to help. I'll clean your back with cold soap. I'm gonna drape up loose numbing medicine. That's the worst part. After that, you should feel me pushing on your back. You feel more than that, let me know. We'll put some more numbing medicine in. And then when I find your epidural space with the catheter, it's gonna feel like a weird fullness is in your back, and I expect that feeling to be there. We'll thread that catheter. We're gonna get it checked, taped, and then we'll have it ready to go for in the operating room because we'll start it there.
I'm scared.
Anytime we do the epidural, there's always a risk of bleeding, infection, temporary or permanent nerve damage. The epidural may not work, you may need it adjusted, bolused, or replaced. And there's also a risk of headache with that. We can talk more about that later if it happens. Okay?
You're just a bearer of just happy joy news, aren't you?
Well, yes,
Uh-huh.
I am, but I'm also very honest. And
I know
I'll
you
just
are,
say,
ma'am.
so
I appreciate it.
if I say, hey,
Yes.
unicorns are gonna walk through and there are cupcakes being served, that's not a realistic expectation.
Right.
But
You just got my
these
hopes
things-
up for cupcakes.
Yeah,
Thanks.
unicorns, right? So,
Well, I've seen unicorns, but that's not.
right.
Look, there was one right there. Hallucinations.
So
Anyway.
there's that.
For
All right.
making her job hard.
But there's, that's that. So, then when the epidural's in and the room's set and Dr. Patel's ready, we'll head back to the operating room. We'll have you scooch from this bed to the operating bed, give you some oxygen, put all of our monitors on and get you off to sleep. When you're asleep, we'll put a breathing tube in. that special one that isolates your lungs. Once we have that secured and checked, we may place something called an arterial line in your wrist over here or over here. But
He
that
has
would
a
be something-
port. Would they use that?
That's an IV, now an arterial.
Yeah.
Okay.
It's
I don't
where
know.
the
That's
same
why I'm
place with-
asking.
Yeah,
See,
so port access is
Yeah, if
the
you were gonna
venous
try and do
system
that
in
while
the
I was
body.
awake, I'd call the surgery off because that ain't happening.
Stop.
Yeah, so the
Freaking hurts.
Shush.
port is the venous system, not the arterial system.
Okay.
So the artery system allows us to monitor and beat by beat blood pressure, draw labs.
Oh,
Like
right,
that.
because they
Sorts of
did that
things.
to Anna. Okay.
So that's there. So that might be something, but that's while you're asleep. You have an IV and you have your port. Should we need both?
Yeah,
We just need an IV access of some sort.
gotcha. All right.
That'll be about it. The risks of the arterial line bleeding infection is a higher pressure system than your venous lines. There's accumulation of blood in the skin called hematoma that will resorb with time if it happens. That's the additional risk. And then you have two blood supplies to your hand. If you have an erroneous or abnormal blood supply, you only have one, and put a catheter in. There's always a risk that you can cut off blood supply to the hand, but we actually monitor during the case with the pulse ox to make sure that you have nice warm hands. I know. I tell you everything even though you don't want to hear it.
No, you're fine. I'm just surprised you remember it.
Oh, yeah, well, I hope so. I
Right.
know. Okay.
It's a lot.
What questions after all of that information do you have for me? Come on in.
Are you left-handed or right-handed?
I'm right-handed.
Oh, well, then there you go.
Yeah.
No, really. Do you have any questions?
No, I really don't.
How
She
about-
answered the main one I was worried about with my lungs.
I have a question.
Yep.
So Dr. Patel had said that they may have to, because of the elasticity lung issues he has, you may have to inflate and deflate and inflate and deflate.
Sure.
Is that like a normal thing sometimes with the COPD? And so
It's
does
a,
it?
It's a normal thing with any surgery when you're working around the lungs. The COPD doesn't necessarily play into it all that much. It's a visualization thing. So if the surgeons need visualization more or less, we either inflate or deflate the lungs depending on things. Now the inflation and deflation, he's probably talking about his ability to oxygenate
Right.
throughout the procedure. And that's just a conversation between ourselves and the surgeons. For
Sure,
what
sure.
he needs, and we sort of,
But going back and forth doesn't create any further risks. It's still pretty much the same kind of risks.
correct.
Okay. I was just
As
curious.
long as they don't overinflate it, pop it like a balloon, we're fine.
Well, you know.
Right.
Well, you know.
Pretty darn
So.
sure that they're good at this thing.
Oh, I
This
have
isn't,
no
this isn't your
problem.
guys' everyday, and
Yeah,
that's totally
so,
fine. And it's
right.
this is the time now to ask questions and
Yes.
get all that stuff answered.
Right.
So,
Sure,
yeah,
sure.
all that stuff is great.
I'm shutting on it for a second.